I'm going to start in just a minute as we wait to bring in our participants. Okay, hello and welcome to today's briefing, and thank you for joining. I'm Brendan Saloner, a professor at the Brown University School of Public Health, and an advisor for this month's issue of Health Affairs, which is a theme issue called Insights about the Opioid Crisis. When planning started on the theme issue last summer, drug overdose deaths were just beginning to decrease from their height during the COVID pandemic, when they topped 100,000 people annually. And though it was not apparent at the time, we can now see that in 2024, overdose deaths dropped below 80,000, their single largest yearly increase since the start of the opioid epidemic, but still numbers that really are staggering from a historical perspective. And during today's event, we'll discuss why overdose deaths may be falling and how policy may affect the number of overdose deaths in the future. We'll also discuss some themes in the policy landscape and specifically what makes this moment so unique. I'm thrilled to be joined by Joshua Sharfstein, MD, for this conversation. Today's event is based on insights from articles published in our September issue on opioids. Health Affairs is grateful to the Foundation for Opioid Response Efforts, Dogwood Health Trust, Kaiser Permanente, and Vital Strategies for their support of its work. Throughout our conversation, participants can submit questions through the Q&A tab at the bottom of the screen. Participants should feel free to enter questions in the chat at any time during the conversation. And now I'm going to introduce Joshua Sharfstein. Josh is the Vice Dean for Public Health Practice and Community Engagement and Director of the Bloomberg American Health Initiative at the Johns Hopkins Bloomberg School of Public Health. Previously, he served as the Secretary of the Maryland Department of Health and Mental Hygiene, the Principal Deputy Commissioner of the U.S. Food and Drug Administration, and as Commissioner of Health for Baltimore City. Dr. Sharfstein also co-authored a book about the opioid crisis called The Opioid Epidemic, What Everyone Needs to Know. It's right here on my bookshelf. And he's a co-author of a forthcoming book called Information Sick about the decline in journalism and the rise in disinformation and its impact on health. So welcome, Josh.
Thanks so much, Brendan,
So
and
I
great to be here.
Great to have you. So I think we decided to take the title of this event very literally and paint a landscape today, right? So we're going to start by putting on our Bob Ross hats and prepping the canvas. And I think to do that, let's talk about sort of that change that I had mentioned in my introduction. So the reduction in overdose deaths that really got underway in 2023 and accelerated last year, which I think is an incredibly important development. So I think my first question to you is just what's going on? What do you think is driving the decline in overdose deaths?
Right. Well, first of all, thanks so much again for having me here. And it is the right place to start. And sometimes we feel like everything has to be getting worse because it's just so bad. But that is not the case right here. Overdoses are declining. And I heard about one meeting where someone got up and said, everything we're doing is not working. And someone said, well, I mean, things are getting better. So we shouldn't assume that everything we're doing is not working. And in fact, I'm sure some of the things and many of the things that are happening are finally having an impact. But there are three main contributors, in my view, to the deaths. And one of them is how many people are using, and that's sort of a measure of despair and the levels of addiction. And we know that that went up significantly during the pandemic because of all the stress and trauma during the pandemic, and that may be declining. So that's one factor. The drug supply has changed quite a bit, and when it becomes more dangerous, more people die. And even if you're doing a whole bunch of successful things, if the actual lethality of the drug supply is getting worse, you that can just be, washed out. And what has happened is that fentanyl has really penetrated the markets, may even be receding a tiny bit, but certainly it just can't keep getting that much worse once it really takes over. So that, in terms of getting worse, may have stalled in a number of places. And then you have what you're doing, the actual programs to help people with addiction, or prevent people from becoming addicted or being exposed, even if they're not addicted, to lethal amounts of drugs. And, that's a big deal. And that has been where the investment is. And so in my mind, and of course, There's also, I don't want to leave out the idea that the way that drugs get into the country is part of the supply of drugs. But I do think that we know that the trauma of the pandemic is receding, and we know that there are many, many effective programs that have been implemented in different places around the country. Naloxone being an example, treatment with medications for opioid use disorder being another example. So I think that there's every reason to be, pushing on the things that work because I think we're starting really to see as the lethality of the drug supply is at least stabilized, we're starting to see that forward progress.
Yeah, Josh, I think that is a really great way of kind of bucketing the factors, and I wonder if we could just take a moment and dive into each of them just a little bit.
Sure.
So, you talked about the number of people who use, and I think I would add to that the circumstances under which people use. So we know that the circumstances of the pandemic created a lot more situations where people were engaging in solitary drug use,
Yep.
which of course is very risky when overdose potential is so high. Do you think that the situations of the pandemic were kind of like a one-off, that it was a terrible thing, we got through it, now we're on the other side? Or do you think that there's things that we should be looking back and saying, hey, we learned good and bad lessons. This is what we can take going forward into our response to the opioid crisis?
Well, I think particularly as you get to the policies and programs, there's some very important lessons from the pandemic. I think, we see the impact of the stress of the pandemic on things not just like overdoses, but homicides, suicides, and we're seeing some certainly improvement on the homicide front. And so I do think that there's evidence that things are getting better.
Right.
How to help people who have had that trauma, how to make populations more resilient to that kind of trauma, those are really important things to think about. And then, as you're saying, there certainly are very specific lessons, particularly in terms of access to services and the importance of maintaining access to services and being flexible about how people can access services. I think the telemedicine revolution in addiction care happened because of the pandemic and so many more people needing to get care remotely. And that has led to additional flexibilities for methadone and buprenorphine, and I think has made treatment a lot more available. So I do think we have to learn those specific lessons, even as we're also learning these general lessons about the level of need.
Yeah, I totally agree. I think that's really hard to reason about how things were so bad and yet they could have been so much worse. And I think that the emergency flexibilities during the pandemic, I think, are a good example of that. Actually, on a lot of metrics, treatment for opioid use disorder held much steadier than we would have thought, and telehealth for sure was a big part of that. And for methadone patients, the ability to get those extended take homes, though, we also know that implementation of that particular policy was quite uneven. Well, I want to turn to the second factor you mentioned, which is the drug supply. And I
Yeah.
think this is a really interesting one that we should be paying a lot of attention to. And it presents a mystery to me, and I wonder if it's mysterious to you. But I've seen across a couple of data sources, including the DEA's National Drug Threat Assessment, some indicators that fentanyl is becoming less prevalent in the opioid supply, and also its concentration is going down. So, do we think that that's a result of policy, of other factors happening internationally, of changes in precursors? What is your best guess of what's going on there?
I don't want to take a stand on something that I really don't understand too well. I've seen some of those things, but it's hard for me to even know how much of that is real when I look at the
Right.
data. Like, different kinds of seizures appear to be a little bit different
Mhm.
in some areas of the country. How significant that is for the actual drug supply is hard to say. There's also the argument, as you know, that maybe xylazine pushed out fentanyl in some
Mhm.
areas and made it a
Mhm.
little bit less lethal.
Right.
It's hard for me to really appreciate that. I can believe that at a minimum, the stability, some level of stability of the drug supply was helpful and possibly even a step back in lethality, and that could have well had an impact. I think it would be great to understand it. I mean, as much as we understand about the value of treatment and certain other, types of approaches, harm reduction, we understand so little about specific types of interventions in the law enforcement and interdiction sphere or other types of things that could affect who's making drugs and how. And, if we could understand more, then maybe we would be able to get at some of those fundamental questions. But I do think that more research is needed to understand it better.
Okay, fair enough. And then the third factor, which you mentioned, and we have a lot of evidence that these things do save lives, is on programs and services. And you specifically mentioned medications for opioid use disorder and naloxone. And if I had to put money on what, which policy tools have been impactful, those would be, where I would put my money too. Um, I think that one of the problems is that although we know from lots of research that these things work, from a macro perspective, it's been very hard to see their impact, right? Because we didn't see deaths going down even as we saw the ramp up of a lot of these tools. So what are you hoping to understand more about the sort of the
Well,
implement?
I think there are two things. Naloxone, you can look at obviously the total amount of naloxone that's out there. But there was a real policy shift at SAMHSA to really focus on getting naloxone to people using drugs.
Yep.
And particularly people who are using opioids at very high risk for overdose. And the amounts of naloxone that were able to reach those populations through dedicated state plans went up like fourfold or more over the period where overdoses were going down. So I think that it is that there is, I think, reason to believe that a policy like that would have an actual impact. The other issue I think has to do with medications for opioid use disorder. There is a growing understanding that there's so much risk in the drug supply that it's really important to get people started in treatment faster. And so you have like the California Bridge program, getting so many people started quickly through through emergency departments. There are many more people who are able to get treated in detention than there used to be. They're not nearly enough, but that really can reduce overdoses because you can prevent the phenomenon of loss of tolerance, which is just, priming people for an overdose death. And so I think that while it's hard to look at the big picture numbers and see, we know underneath that the focus and some of the particular kinds of initiatives are really well suited to have an impact on mortality. And that's why I do think that they have contributed. Exactly how much, it's hard to say, and that relates to that question that I can't really answer on the change
Right.
in drug supply.
I think those points are really well taken, and it gives me a good chance to lift up three articles in this month's theme issue. One about disparities in naloxone use and access, and really an important article showing that racial minority populations still lag behind white Americans in their ability to access and use naloxone. So I think there's still progress to be made on that front. An important piece profiling a telehealth program in Maryland jails, which has expanded buprenorphine access to incarcerated people, and some important work that really highlights the growing importance of Medicaid in financing and delivering medications for opioid use disorder. So please check out
Right.
those. I think those are really important.
And the California Bridge
And the
article.
California Bridge, that was the other one I was going to mention,
Right.
a great piece on California
Yeah.
Bridge. Thank you for that, Josh. Great. So I think that we've got our canvas prepped. So let's start filling in some of the details about where we're at now. And I think that if you had asked me also a year ago, what's going to change in opioid policy, I could have never cooked up the sort of the set of things that we've seen in the early months of the Trump administration. And just to kind of rattle off a few things, fentanyl became very important almost on day one in terms of the administration's stance on tariffs against Mexico, China, and Canada. Obviously, a huge focus now on the southern border and the idea that the southern border is a point of entry for fentanyl and tying that issue up with immigration. And then more recently, we've seen, an
And
executive,
allegedly the northern border too.
and the northern border too, though we're still looking for really solid evidence at that point. So what do you think is going on? And I guess the other thing that I was just about to mention is the executive order. And I think you could throw in some other factors there. But what do you see as sort of the impetus or the kind of the animating force behind all of these policy changes?
So I think it's an interesting question, given how we prep the canvas, you know? And so I think that the question of the changing drug supply shoots out, you know, implications in all directions. And this administration is focused on the importation, the interdiction, and has tied that to its other policy agendas on tariffs and immigration. Um, I think the problem is that because we don't really understand that much about what is happening and why, and it's hard to say whether these are going to have any impact on it. But I do think that there is the basis of like we don't want fentanyl because it's killing people. I mean, that is true. Fentanyl has been, the changing drug supply has been a huge issue. So I sort of tie that there.
Hmm.
The executive order, though, is hard to tie to places, really, because it starts with the idea that people who are using drugs and are homeless really shouldn't be out there, and but it doesn't really provide, the support or a framework to really help them, in my opinion, and so you they're focused on the outward manifestation. Yeah, I'm not sure it's really responsive directly to the overdose crisis. I think it's more responsive to what we might also call a theme in 2025, which is greater attention to public disorder. And
Yeah.
and that, isn't just limited to the new administration. That was seen in a number of states as they loosened some of their enforcement laws, and there was a big backlash against that. And I think the animating force for the executive order is probably that. In other words, you can sort of tie a dotted line, or you draw a dotted line to that political force,
Yeah. Yeah. No.
rather than to overdoses per se. I just don't know that. In fact, a lot of the things that are proposed in that executive order, the hostility to evidence-based, harm reduction programs, I don't think or if anything, will have a counterproductive effect on overdoses. But I do see it tied to something that is also out there somewhere on that canvas.
I totally agree with you. So for those who didn't follow this, the executive order is called Ending Crime and Disorder on America's Streets. So right there, the idea of disorder is put front and center, and it calls for the federal government to use a variety of tools. I think the legality of some of these things hasn't been totally tested, but really they're trying to put pressure on cities and states to take more aggressive actions against people who are unsheltered and homeless, people with mental illness, people with substance use disorders, and apply tools like civil commitment. They say in the executive order that they're against harm reduction, and yet we saw clarification coming out of SAMHSA not long after that saying that harm reduction is forbidden, but tools like fentanyl test strips, naloxone, drug checking programs, all of these things are still permitted, which I think probably caused some of us to raise our eyebrows. But I do think that it's an interesting development. But Josh, I think as you noted, it ties back to things that we already were seeing happening in the blue cities and states, so to speak. So, I think the momentum had been broadly pushing toward more of a law and order posture. And in some ways, we are that pendulum keeps swinging back and forth, and we are in a moment where um, war on drug tactics are becoming much more pervasive in our approach to opioids.
Yeah, I mean, that's always been there in the United States. It's sort of the easiest thing to reach for.
Mm,
And so that gets brought into this discussion. I do think, in my own view, that it's kind of a counterproductive response, that there's a way to look for a synthesis. And I think that's one of the challenges for us all to be working on, which is how do we achieve public health and public safety? We want communities to feel safe, and we want fewer people to die of overdoses, and people to be able to live the lives that they want to live, free of addiction. How do we achieve those things together? That is not really how the executive order reads. I mean, so it is, I think, very much a reaction to this concern that people have about public disorder,
mhm,
and not so much tied, in my view, to the evidence of what works. So I do think we could talk a little bit more about the idea of civil commitment for addiction, which is certainly one of the question marks, how far people will go and what policies will relate to that. There's a lot of concern that that will look a lot like just locking people up for using drugs.
Yeah, I think that's really well said. And I also want to just kind of lean into this idea that you're putting out there that there is this sort of constructive and collaborative space between public safety and public health. And I think that there's still an opportunity that we shouldn't miss to find ways to create those bridges. In this month's theme issue, there's also a really important piece looking at the evidence around problem-solving courts focused on people who use drugs in Indiana and actually finding that in that state, those courts have had a beneficial impact. But the implementation of those programs is really key. And I think that's probably the same point we could make about civil commitment laws. We could imagine it going better and we could imagine it going very, very badly. And I think that that's the peril that we face at the moment is not really knowing how implementation will work. And
Yeah.
I think the other piece of it, which is relevant here, is the resources that would be used to support these programs. So the administration is asking for broad cuts to SAMHSA, the CDC, the NIH, and other federal agencies. And then we just got through some major cuts to the Medicaid program. So how do you understand sort of that piece of changing federal policy and its potential impact?
Right. Well, it took us, how many minutes? 21 minutes to get to Medicaid, which, as you pointed out, this issue has some very important pieces about how significant Medicaid is for access to life-saving care. And the effective use of Medicaid programs, I think, is one reason why we've seen a decline in overdoses and, in some places possibly other beneficial outcomes can be contributing to the reduction in homicides in different ways too. So I think that it's a big deal. And you said we just got through it. We just got through the legislation, but we're just starting the implementation.
Mm.
And it's going to be over the next few years that we're going to see states lose an awful lot of money. And there really are, some major questions here. One is how the exemption process will work because people with addiction are exempted, but the process itself could be so hard that people with addiction are just can't access the exemption. But on top of that, the scale of the likely cuts coming to states are going to mean cutbacks, and that could very easily affect the services that people have come to rely on. So I think the impact there is going to be enormous. And then you have programs that, many cases have been evaluated and found to be promising or effective from SAMHSA. You have critical research from NIH. You have the CDC work, which really, really helped. I'm working at a public health school as you do, and you know, sometimes it's easy just to think about this as like, well, we have to get individual services. But what we've really seen, and CDC's played a big role in this, is that, and SAMHSA too, that states have come together with real plans and have a much better sense of the nature of the problem than they did 10 years ago, even. And that really helps make sure that even all the different resources, including the litigation resources, Medicaid programs, they're designed around the problem, but you start to lose visibility if you don't have resources to stand up that public health response.
Yeah, Josh, how worried are you about the possibility either for malicious or negligent kind of reasons that some of our ability to even track what's going on is going to go away? And, to the extent that you're worried, what should we be doing or thinking?
Well, you know, I I can't really speak to malicious or negligent or what, I do think that we know that the parts of agencies that are responsible for critical data collecting and sharing responsibilities are getting hit pretty hard, and a lot of people have left. And sometimes you lose expertise that is really hard to recapture. That's what I'm worried about, not just in this area of public health, but in other areas of public health. And just degrading the quality of evidence is one part of it. And then degrading the team and the ability to respond, which is what some of the overdose fraction grants were really supporting, is another dimension. I think it's going to fall to states and localities to really make sure that those functions are kept up. And it's hard because if it's like, well, are we going to cut, a few doses of naloxone? Are we going to cut, rates for treatment programs? Or are we going to cut this group of people that it's not quite clear, it's not so intuitive what they're doing. What they're actually doing is figuring out what's happening and making sure that the rest of it is working. That's my fear that like as the budget constraints come, the the part of this that actually has played a really important role in getting the right response to this problem is one of the first on the chopping block.
Yeah, Josh, I know that you often field calls from folks who work in city and state government, and I wonder what your advice to them is right now, especially if they want to not lose momentum on this challenge. And if we see the federal government somewhat stepping away, what can be done at the state and local level to continue the momentum?
Well, I think it's really important now, and I do get a bunch of those calls. I teach a course on public health crisis and response, and I give talks on that topic. And I always tell people like, call me when you're stressed out. So it's partly because I miss being in the public sector and being I don't miss being stressed out all the time, but I miss a little bit of that. And so I do get calls, and there are all kinds of situations that arise, and often what happens is that there are political forces, people who are very popular, entities that are very well known, that are making claims on policies or resources that a public health official knows won't be used that well. And this is going to become a bigger problem as resources start to constrict who gets cut. When things are growing, it's like, okay, this treatment program maybe isn't doing that great a job, or they have this policy that I don't like that much, but like I am able to fund all these other good things, it's fine. But
Yeah.
when the tide starts going out, these issues become more intense. And so the need to really explain to people what's happening and what's valuable and where you're seeing an impact, and hopefully when times were good, you were able to tell that story and get some data about it. That's going to be really important. And these aren't the easiest conversations, because I think more generally with drug policy, our in this country, our intuition isn't always aligned with evidence. We think what'll work isn't the things that work, and the things that work we don't like to talk about or want to do. But we're gonna have to push through this, and you have to get people who've actually been affected. I'll tell you one story. When I was the health commissioner of Baltimore, we had a big buprenorphine initiative. This was before all the stuff. This was in the mid 2000s, and we trained a bunch of people. We organized our treatment system. We had a hub and spoke model, and we got some serious pushback. The local newspaper wrote a huge story saying that, some of the buprenorphine was getting diverted to the street, and, I was responsible as the health commissioner. They described me not entirely favorably, or maybe not favorably at all, as the Johnny Appleseed of buprenorphine in the story. And after those stories came out, the General Assembly in Maryland decided to hold a hearing about what we were doing. And people were kind of anxious, and they came to me like, uh-oh, this is how it all starts. The paper is going to start writing about how everybody has questions. And I said, I think we're going to be okay at the hearing. And we brought people whose lives had literally been saved by buprenorphine to that hearing. And they told their story. They said how much the medicine helped them, how happy they were to be doing it. They talked about their lives and what it meant. It was the most public discussion of drug treatment that I'd ever been part of in my time in Maryland. And the people on the committee, including, people of all political parties, different parts of the state, were saying things like, how can we get this in our community? Like, my friend's son or daughter is having a problem. Talk to me about access. This was back when buprenorphine was really just coming on the market. How can we do this? And so we can't be afraid of losing those discussions. But to a public health person, I would say, and this has to do with my new book, you're not the only messenger here. You really got to broaden. You've got to find the community leaders who really care about what's working. Got to find the patients whose lives have been saved and are willing to talk about it. That's what's really, really important in this moment.
I think that's such an important general point about some of the communication challenges we've had around this crisis is that we've been fed a kind of a constant supply of all the things that are going wrong. And when things go right, we often don't really see it or experience it in the same way. There's,
Yeah, yeah. Let me just say, in other fields, like, the weather is a little nicer, and like the meteorologist is taking credit for it. You know what I mean? I mean, like, even if they have nothing to do with it. I mean, that's a tiny exaggeration, but not that much. in our field, something starts to go in the right direction, and people are like, we can't lose sight on how far we have to go. Like, we absolutely can't lose sight on that. But it is okay to say that things are working and that this is how we've made progress and we don't want to backslide. It's okay because it's important for people to realize that that kind of progress is possible. In my career, I've seen on issue after issue progress being made. That's
Mm.
why we do this, is to make progress. And the fact that something's working, or at least there's a very strong argument for it working, is something we should absolutely not be shy about.
Yeah, I love that, and I think that it sort of plays well into the fact that we're in this perilous moment right now because there's not a sort of a dominant narrative that we have about what this crisis is about. So to the extent that the public has started to think about it, they've been thinking about it from a kind of a threat perspective, and I think that offering a kind of a counterweight would be really
Yeah,
valuable, finding those
I
connections.
remember this one moment that was a little incongruous, which was finally New York was going to open an overdose prevention site, and there were like pictures of the health department team, popping champagne or apple cider about
Uh-huh.
it. And it seemed like, like incongruous. Like, why would you do that for anything related to this horrible topic, you know? But then, the truth is that center has made a big difference for people, and a lot of people have gotten all kinds of services through that center. And there has been evidence showing that, crime and disorder has not gone up, and there's all kinds of ways that they have worked, even with local law enforcement around that. And these kinds of things are solutions, and we can be happy when we get, well running solutions. We're going to be checking, we're going to be studying them, but there is an element of enthusiasm that is important. And the enthusiasm is based on just the fact that we expect, based on evidence, that these things will actually work and save lives.
Yeah, I think that's really well said. So I've been keeping an eye on questions coming in the Q&A, and if you have a question, please don't be shy. Drop in your question. Some of the questions that have been coming in have been pointing out that we're in this complex crisis that's not just an opioid crisis, and there's other drugs that are also contributing to rising overdose that what had been a rise in overdose deaths, and I think still remain very much kind of drugs of concern, so methamphetamine, cocaine, other kinds of novel stimulants. How should we think about how to widen that lens so that, yes, we really recognize opioids have been the dominant story for more than 20
Yeah.
years, but other drugs are still very much threatening the public's health?
Well, it's absolutely true. And I think that has important implications for policy in different ways. One of them is our treatment system and treatment programs have to be able to handle that. It can't just be, go somewhere else for the other drug that you're using. Treatment programs have to be able to do that. And it means that they need the tools to do that. And that, is going to include other things, for methamphetamine and cocaine, it'll involve different types of behavioral therapy or contingency management. We need to equip, train, support those kinds of treatment programs. It also speaks to the importance of data and really understanding what is in the drug supply and what kinds of combinations are dangerous in different ways, and how they're dangerous, so that different kinds of responses and everything from the talking to people about the risks that are out there, the use of drug checking, all the way up to changing treatment programs. It's it's important, and some of the key sources of data that we have are, essentially quantitative surveys that are being done. But I also think it's really important in this context, if we're really thinking about the full range of substances and the ways that people are using drugs, to get qualitative data, kind of ethnographic research. And some of the papers in the health affairs issue, provide some of the texture to why that kind of engagement is important, how different groups of people feel about using drugs, what's happening. That's an important part of our surveillance system. And I think it's an example of where there have been a number of academic studies, fewer maybe big government studies, but we have to be able to bring that together. And I think policymakers should be reaching out to academic partners to say, I really need to know what's happening in why people are using drugs, how they're using them differently. Can you get me information on that? Because that will help all kinds of different aspects of the response.
I think that's really well said, and it also speaks to the sort of the degree to which we're really not in a monolithic opioid crisis, but we have multiple crises stacked together. Another questioner asked about, the fact that this is basically asked, is this illicit or an illicit drug crisis? And I think my answer would be both, in that we still very much are living through a prescription opioid crisis, but illicit drugs are very dominant in terms of overdose deaths. But how should we think about sort of the heterogeneity of the populations that are at risk and the need to tailor
Right.
our tools and approaches to different kinds of people?
Well, I think one of the casualties of just the massive surge in fentanyl has been the discussion that we were having in this country about the best way to address the treatment of pain. Like that has dropped a little bit off the radar screen. Or to go back to our metaphor, it's dropped a little bit off the canvas, but it really shouldn't. And especially perhaps as deaths from fentanyl are going down, maybe we'll be able to revisit that conversation because there are some very important threads there, both about how we make sure that people aren't started on opioids when they don't need it, how signs of misuse and addiction are picked up quickly, but also about how there were some very aggressive, broad brush strategies to knocking people back from opioids that probably, or I do think, did harm to a lot of people, and how to find that path through, where people who really need opioids for pain can get them and get support. But there are also all kinds of other modalities for pain treatment, and that we're not, starting everyone who had wisdom teeth out on OxyContin. And there's been a definite progress made there. But if you look at the number of people getting opioids still, and if you look at the stories that people are told about how hard it can be to get pain medicines, even, for people who evidently need it, there is more work that needs to be done there.
Great. I think when we also think about the heterogeneity of this overdose crisis, it's important to draw attention to sort of the tails of the age distribution. So there's a crisis right now among older adults, which may, be very much tied up with issues like our chronic pain crisis. And then there's also rising overdose trends among adolescents. And you're a pediatrician, Josh. Let's just take the adolescent piece first. What do you see as the sort of the key policy tools that we should be thinking about for younger folks and getting kind of better services and treatments for people who are still in that sort of formative growth age?
Well, as a pediatrician, I'd always start with prevention, and kids are generally not that many years away from, not having started. In other words, you see, sometimes you come across an adult and it's like, I've been using for 30 years. It's like, okay, but for a child, it's like, well, I started 6 months ago, and so you have to wonder, like, are there ways to intervene right then, but could we have intervened before? One of the most important observations that I had somewhere between pediatrics and public health is that most kids, this is not true for everyone. In some cases, you have like the straight A student who gets the prescription and, goes down a path of addiction. But most kids who are getting into drugs are generally having trouble with school or work, and you know, um, drug use is one of a series of risky things that they're doing. And I think it's important to shift the prevention discussion to really helping kids thrive in school or work. And that is kind of an immunization against drug use if you can do it. And so the kinds of programs that are really able to help kids, succeed in school or go to alternate paths for jobs. Those kinds of investments are extremely important, and I think a good use of, money intended for prevention. When you get into treatment, the pediatric community plays a really important role. Early identification is very important. This is another area where, before an adult, gets up and has breakfast, there are 12 new trends in drug use among kids that the adult doesn't even know about. So figuring out how to have a really good surveillance system and being on top of what's going on, it involves talking to kids and figuring that out, and then, having a way to get good information into those networks in ways that people will actually listen. So, it's really important to intervene in those ways. I mean, the stories that I've heard from parents who really didn't know what their kids were up to, and the kids really didn't know, and like there's like a flash trend that happens that affects them terribly, really is challenging. And I do think that like just the nature of the way information is moving these days, this is like something we have to pay attention to.
Yeah, Josh, I'm of a generation that was raised on Dare, which I think, at least in its earlier incarnation, was not shown to be a very effective program.
Right.
Where does the science stand now on prevention and trying to kind of do some of that more?
Yeah, I'm of the generation that was this is your brain on drugs, and it was an egg cooking. That was my generation. I think that there are different threads here. I mean, there's specific programs that have been evaluated, and some of the challenges is that some of those programs are very expensive, and so a program might work great, but it's not feasible to scale. So a really important question is how do you do both? How do you find effective programs and scale them? I really do think it's critical to be in very good partnership with schools. And my personal view is that we're talking about the more general resilience of kids, the support that they need for challenges that they're facing at home, the support that they're getting for their mental health challenges, and basically their ability to succeed. Even when we had just a little bit of money for prevention in Baltimore. We put a psychologist on the sixth grade, team that was going around trying to find kids who were missing so much school they were at risk for dropping out
Mhm.
eventually. And I thought that was a good investment, even if they're not sitting there showing them pictures of eggs frying in a pan, they're helping kids reconnect to school, figuring out what's going wrong in the classroom, teaching the teachers how to better engage with students so that they don't get turned off. That's a lot of hard work, but it's really important.
Yeah. Yeah, I always got hungry watching those egg ads.
Mhm.
Um, and on a more serious note, I do want to put in a plug for another great article on the adolescent treatment continuum, which is in this month's theme issue.
Right.
It really shows the stark disparities there. I also
And
want to
and overall, the huge gaps in access to care.
huge gaps everywhere, but I think for adolescent serving practices and adolescents getting care, really profound challenges to overcome. Maybe transitioning a little bit to older adults and especially to people who depend on institutional care. There's also a great piece in this month's theme issue about the continuum of care in skilled nursing facilities and nursing homes.
Yes.
And I know you've thought a lot about sort of, what happens when people go to the hospital, when they need to continue on care in the community, and the fact that it's very hard to get access to treatment in those kinds of settings. I know, Josh, also that you're a proponent of using sort of stronger tools to get the healthcare system to come around on these issues. So I'd love to get your thoughts on sort of what tools we could still be using in public health to strongly encourage, let's say, more evidence-based care.
Yeah, I mean, you're exposing me, but I will confess, I go to meetings and people talk about all the ways to incentivize people to do things. And I think in other areas of medicine, we wouldn't necessarily be talking about incentivizing. We'd be slapping our, foreheads and saying, how come we're not requiring them to do it? Imagine if patients weren't getting insulin in the middle of a diabetic ketoacidosis, it'd be like, what is going on here? And in cases where patients are not able to get access to life-saving treatment, it really is a question of clinical quality. And when they're big enough questions of clinical quality, it really raises the issue about the overall management of the system. When we wouldn't permit truly egregious, persistent care for other conditions, why aren't we taking stronger action in this case? And it's not that I don't agree with incentives. I'm all for incentives, but sometimes you get to a point and you say like, should there be a regulatory requirement if incentives alone are not enough? Because often you're bumping against stigma. And,
Mhm.
I've had this experience at one point, Dr. Ingvild Olsen, who's my wife and the former director of the Center for Substance Abuse Treatment, and we wrote a book on addiction, and we were contacted by a hospital system that wanted to do, it was a partnership with us. So that sounded exciting. We didn't know what that meant. And we got on the phone and they said they wanted to like brand their opioid efforts with our book, which seemed a little confusing, but we were open to it. It didn't sound bad. And then they said, and so like, do you have any questions for us? And we're like, well, do you treat people who come with addiction to your emergency department? And they said, we really don't want to encourage people to come to our emergency department with addiction.
Uh-huh.
So no, we don't. And we were like, how could that be? You're supposed to be this great hospital. You just gave a 20-minute introduction to what a great hospital you are. This is such an important, quality issue. And at a certain point, I've been going back to how old I am. Like, I'm too old to just keep thinking, like, how do we incentivize them to do the right thing when it is really a question of life or death for their patients. And so I do think at different levels in the healthcare system, this is a fair conversation for people to be having. I think it's very, very disappointing that there are a number of nursing homes that cannot offer really critical life-saving treatment. And it's even worse than that. It's not just that they can't do that, it's that people who are on life-saving treatment are being forced off of it in some cases. And that puts them at super high risk for overdose. And, it's just unacceptable in my personal opinion. And we have to figure out ways around that. That means providing all the resources, having the incentives, but getting to a point where it is necessary if you're going to be reimbursed for a certain level of care for truly important evidence-based, care to be provided. And I don't mean evidence-based because I woke up in the morning and thought of that, but it's really the true professional consensus standard for how to save people's lives.
I'm going to make my own comment about this, and then I'm going to go lightning round so that we get in
Mhm.
some of these great questions coming in the chat. So, I think that I'll now say a comment in my dotage that since I've started working on this issue over the last decade, I've seen huge progress in hearts and minds, and I do think that we are making a lot of progress. I think naloxone has become so baked into sort of mainstream approaches to this in a way that it wasn't in the past. And also, I think that we're just having different kinds of conversations on these issues. And, one of the things that I think is really encouraging is that if you look at medical trainees, their views of addiction and their receptivity to treating addiction is just increasing a lot. So, generationally, I'm very hopeful that we'll get to the right place and how to kind of accelerate that change. I think, some of your comments really connect back to that.
Yeah, and in case anybody's wondering, we did not do a partnership with that hospital system. Anyone who knows my wife or me
You
probably.
wanted to do it, but Dr. Olson
Yeah.
was this.
Yeah, that
Um,
was never gonna happen.
All right, great. We're gonna go lightning round on some of these really great questions. There's some questions in here about naloxone and especially naloxone's effectiveness and the effectiveness of naloxone in the context of xylazine, which is not an opioid and also
Yeah.
causes sort of strong respiratory effects. Um, what should people know about the effectiveness of naloxone right now? And does naloxone work if people have xylazine on board?
It's important if people are not breathing to give them naloxone. I think that's an important point. Um, I think that it doesn't have to be a super high dose. It
Hmm.
doesn't have to be the extra high dose. I think there's evidence that the regular dose is a good place to start, and a lot of people respond to that. Um, if xylazine is often used when it's mixed with other drugs, so you would give naloxone and it would have an effect on the other drugs, particularly. I'm not exactly sure of the precise effect on xylazine, but xylazine is, my understanding is that it may affect the degree to which people wake up. Like if you're just on a pure opioid, you give naloxone and it's just boom, the person is awake. But that may not be the case with xylazine, but it's certainly not a reason not to give it to save someone's life.
Great. Yeah, I think the public health messaging got a little tangled up, not in what you said, but what some people learned about. And I think that the message to still use naloxone is still very relevant and important. There's a question in here about whether I think this is the elimination of the X waiver worked to get people buprenorphine. Do we know what happened there?
My understanding is that it's been underwhelming that the number of, but you know better than me, Brendan. But my understanding is that the amounts of prescribed buprenorphine, the number of prescribers hasn't, surged, I think maybe to everybody's hopes. I
Yeah.
do think that it's probably helped on the stigma front. We've got new generations of physicians, coming out, but I don't think that legal change will probably be enough. I've always felt that it's very important for doctors and other providers to learn how to take care of patients in their training during their residencies. And the evidence is there's still a lot of programs that don't provide that teaching. And I do think that should be required. Like, I don't think you should be able to get through certain types of medical training in specialties if you don't know how to use insulin for diabetes. You shouldn't be
Right.
able to get through if you can't use buprenorphine for opioid use disorder.
Yeah, in a piece that I wrote with some colleagues a few years back, we made the distinction between buprenorphine dabblers and buprenorphine specialists, and there's still
Mhm.
very much a role for clinicians who dabble in buprenorphine. They may not have a core practice in addiction medicine, but if they see a patient in their clinic who could benefit, they should be prepared to use it because as chronic disease medications go, it's relatively straightforward to get a patient.
And the thing that's absolutely true, and I can say this from having, run or overseen programs that involve a lot of prescribers, is that it's like a light bulb turning on for a lot
Mhm.
of people. If they get started, you can move from a dabbler to a prescriber because it's so rewarding. And a lot of the frustration that doctors feel with patients who use drugs, can be brought down if the doctors realize that there's a tool that it can actually help.
Yes, I think that's right on. A question here about whether there's a distinction for this administration between harm reduction and overdose prevention. Are these really just different terms to be leveraged pro and against the same activities? So overdose prevention and harm reduction, do you see a distinction, Josh? And do you think the administration kind of is just using a new phraseology for something they don't want to discuss?
Yeah, I mean, I think that the harm reduction is not just individual programs, it's a bit of a philosophy that we're going to respect the dignity of individuals, even as we're trying to help them regain control of their lives. And overdose prevention is maybe a little bit more neutral, doesn't have that connotation of that philosophy. And it's more like outcome oriented, it's just preventing overdoses. In terms of where the administration is coming from, they've made very clear that they're not big fans of overdose prevention sites. The data notwithstanding, they have significant policy or moral concerns about them, and so they would put that into the category of um, types of programs that they don't like. I'm not sure exactly that what we're seeing with this administration is a rejection of the entire philosophy of harm reduction. I do think that there are people who recognize, like, these are brothers, sisters, mothers, fathers, children, and so they want to be able to meet people where they are. I think when they use harm reduction, they're thinking about specific programs, or I imagine they could be thinking about specific programs that they just don't feel so good about. But, you know, that's what people said about naloxone. Again, I'm old
Right.
enough to remember when I couldn't get, legislators even for Baltimore City to be supportive of public health models for naloxone distribution because of the intense stigma there. And so I think you can wear that down with evidence and experience and the stories from people who've actually succeeded. And, maybe then things will cross over from being in the category of quote harm reduction to the category of overdose prevention, but will be more in line with this idea of helping people in their moment of need and supporting their dignity.
This is my last call for any new questions, but I'm gonna keep going lightning round here. Um, Josh, your screen is about to turn off.
Oh, okay. Sorry about that. This is my legacy of
The
my
countdown of
COVID
doom.
setup here.
Um, so another good question in the chat about the role of the faith community.
Mhm.
And I'm also curious to get your thoughts about how faith leaders can be engaged more explicitly in terms of responding to the overdose crisis. What models have you seen that have worked? Do you see any tensions there? What are your thoughts?
Yeah, well, I think it's really important because there has been such a overlay of right and wrong and drug use. And, the faith community is the arbiter of right and wrong. And so, people experience such shame when someone in their family has a problem with drugs. And it's the faith community that can help undo that and help get people help. And you can have ministries, and there are ministries where people, are there for people and are able to channel them to whatever types of services that they need. So I absolutely think it's a very valuable partner. And you want to, it's another reason why a public health approach is really helpful because, public health is looking for partners to accomplish goals, and you can really make good partnerships. I was once at a meeting, sorry, just one more quick story here, where there was a church-led program that, was absolutely opposed to any use of medications for opioid use disorder. And it was really just about praying. And, you know, prayer can be very important, obviously, for people, but so can medicines, and we don't, in my view, they don't have to be one, it's not one or the other. And it just made me sitting there so angry, just to hear that like they were set against each other. We don't believe in these medicines, do we? And I thought about like raising my hand and asking an obnoxious question, and like in an amazing moment of, you know, restraint, I said, why don't you just talk to the person one on one? And I went up to him one on one, and I tried to think of the best way for me to express what I was thinking. I said, do you ever wonder for the people who you try to help and you can't? Because he admitted that there were some, whether or not treatment with medications would have made a difference in addition to the program that you have. And he looked at me dead in the eye and said, every single day. And
Mhm.
that opened just a totally different conversation, you know? And so I think even where people are going off maybe in a direction that people who are more tied to evidence would say it's concerning, you can't close off the conversation.
Yeah, Josh, I think that's a moment of public health grace, and I think it's a good reminder for all of us in this field to stay curious and open to understanding how people understand these issues themselves and having some of those bridging conversations. So I think that's a good lesson to end on. And I'm going to now make a few announcements, but I'm just want to say thank you so much, Josh. This was such a critical and important and helpful and clarifying and fun conversation. And thank you to everyone who attended. Thanks to the Foundation for Opioid Response Efforts, Dogwood Health Trust, Kaiser Permanente, and Vital Strategies for their support. I do want you to know that Health Affairs has two upcoming events. September 29th from 1 to 2 p.m. Come Eastern Time, come from Mark Fendrick of the University of Michigan, who will host a panel discussion exploring the current state of prior authorization. October 15th from 1 to 2 p.m. Eastern Time, Arturo Bustamante of UCLA will host a panel discussion exploring immigration policies and their impact on health care. You can find out more about Health Affairs events on its website, healthaffairs.org. Again, Josh, thank you so much, and to our audience today. And with that, we are adjourned. Thank you.